This is Selma Schimmel in Washington, D.C. at the Community Cancer Care Advocacy Day Forum, an event that Vital Options International and COA, the Community Oncology Alliance, have sponsored together. And now I'm joined by Matt Brow, who is Vice President of Public Policy and Reimbursement Strategies for the McKesson Specialty Health and U.S. Oncology Network.
Thanks, Selma.
The general public keeps hearing the Affordable Care Act, but maybe you can simplify it and explain what exactly is the Affordable Care Act? What is it meant to be?
Sure, that's a great question, and there's a lot of misperception about that out in the country, I believe. There are really two broad aspects of the Affordable Care Act. The first is trying to expand health insurance coverage to about 30 million additional people, about half and half through an expansion of Medicaid, and in the other half through the creation of a new set of exchanges that the government will subsidize the purchase of private insurance for folks that are under 400% of the federal poverty level. Those are all paid for by a set of new taxes on individuals, particularly individuals over $250,000 a year of income, taxes on health insurance companies, on pharmaceutical companies, on medical device companies, and then a wide variety of cuts to other spending, including what many people have heard about is around $700 and some billion in cuts to Medicare. And all of those things are true. The other big piece of the Affordable Care Act is the creation of a new regulatory regime at the federal level that for the first time puts a really significant federal imprimatur on healthcare and healthcare insurance in this country. In large part, it regulates everything that insurance companies do in this country, from how much they can charge to what kind of coverage they have to offer, to whether they have to give coverage at all, which of course they do in every case according to the Affordable Care Act. At the same time, that regulatory regime applies to individuals and employers in this country and says to each, in certain ways, you must either buy insurance for yourself or for your employee or face a penalty. And that's often known as the individual mandate. But those are really the two core issues there. You have this big coverage expansion paid for by cuts and taxes, and then you have a new regulatory regime that didn't previously exist that provides some structure and almost a regulated utility approach to the way that the government looks at healthcare insurance.
Prior to the Affordable Care Act, was there any governing body that did oversee the insurance industry?
Yes, there are approximately 53 of those. Each state level has a Bureau of Insurance that looks over the various insurance kinds of products that are offered in a state, whether it be health insurance or casualty insurance or something else that you might find. And then the district and the other territories each had their own bodies that did that as well. So for the first time in a very significant way, this is federalizing the regulation of health insurance.
And then at the state level, what happened to those regulatory agencies?
They still exist in so much as they can take further action in addition to what the federal government has done. But much of what they might have done or might not have done is preempted by the federal government's approach here.
So Matt, how does this health care reform affect and truly impact community cancer care?
The core issue really is there'll be more patients that have coverage. And as you know, and everybody watching probably knows, diagnosis of cancer and the treatment of that diagnosis can be extraordinarily expensive. To the extent that one would face that without any health insurance coverage, that would be very difficult. So we'll have 30 million more, give or take, insured lives in this country, and that's out of a current uninsured population of somewhere around 45 or 50 million. So about 2/3 of the folks that are currently uninsured will be insured. And then there are some other protections in the law that go a little bit further. In particular, I think it's important that the law requires health insurance companies to pay for the routine cost of care associated with participation in a cancer clinical trial. And that's something that didn't exist before. In certain states it did, but not at a federal level, so that's important. And then the law also provides significant and meaningful caps on out-of-pocket expenses for all beneficiaries of all plans. And that's important for a cancer patient when facing such an expensive course of care.
What happens for the cancer patient who needs a costly therapy, but it's beyond the reimbursement possibility of their carrier?
Yeah, typically today that is possible in certain instances, but it would be prohibited under the Affordable Care Act. There are no annual or lifetime maximum limits allowed under the Affordable Care Act starting in 2014. So while in narrow instances that happens today, where somebody might hit $1 million threshold or a several $100,000 annual threshold, that one is unlikely, but even so would be essentially impossible.
And what about access to treatment that is considered super costly and doctor feels it's essential, but it is questionable because of the cost involved?
Yeah, it's an interesting question, and it's one that most health insurance plans and the federal government haven't even hardly begun to grapple with. Right now, typically what happens is they pay for it, and that's part of why the costs associated with taking care of cancer patients are rising so rapidly. Most patients are not prevented from receiving the care that their doctor prescribes for them.
One of the areas of concern is imaging.
Sure.
And trying to get access even to things like, a PET CT.
Mm-hmm. Yeah, in this area, both the federal government and the private payers have taken a more strenuous approach to regulation in this particular space. In the imaging, particularly PET CT and CT imaging, and to a certain extent, MR, magnetic resonance imaging. Mm-hmm. But really what they've done there is not so much said no, but put a whole set of difficult administrative hurdles in between the patient and the scan that the doctor has prescribed.
Yes.
And those could include prior authorization or a step approach where you have to do this one first, an x-ray, and see if you can figure it out from that, and then maybe you can try a CT scan a couple days later, or maybe not. And also many private plans in particular have taken an approach to change the copay or coinsurance associated with different sorts of tests to try to incent a patient to take a different approach, a less expensive approach.
Let's talk about the Supreme Court decision and how that affects the future of the Affordable Care Act.
There were two core questions really before the court in this instance. One was, is the approach to the individual mandate constitutional, which for the first time the federal government not just regulating commerce, but in fact requiring of citizens that they engage in commerce. Is that an acceptable use of the federal government's power under the Constitution? And then the second question actually turns out to be a more interesting one over time, which is to say that the second question is the way that the federal government has incented states to expand their Medicaid programs constitutional in that, one, there's such a large amount of money coming on the basis of the state policy decision, and two, the federal government actually in the law threatens or would actually pull back existing federal funding for Medicaid programs to the extent that states don't make the Medicaid expansion. In the first instance, what the court found was that the individual mandate is not constitutional from a Commerce Clause perspective, from a regulation of commerce perspective, but because it is structured as a tax, it is constitutional under the federal government's taxing power, which means essentially that anything that the federal government wants you to do, arguably it could incent you to do by taxing you if you don't do it. It's a taxing of behavior kind of issue, which now, at least for the moment, in this particular era, is constitutional and could have significant non-healthcare ramifications over time. On the other side, when you think back to the way that the federal government has used funds as a coercive approach over the last 30 or 40 years, the instances are numerous and significant. I mean, there wouldn't be or wouldn't have been a national speed limit without a coercive federal government approach to highway funds. Similarly with the drinking age of 21, that never would have happened if the federal government wouldn't have threatened to pull back highway construction funds if states didn't pass those policies. What the Supreme Court said was that the way that the ACA approaches the Medicaid expansion is unconstitutional, and that gives the states the leeway to decide whether or not to expand their Medicaid programs, and many states have already decided that they will not. That puts, obviously, the expansion of coverage for some of those 16 million people who are expected to be covered under Medicaid through the expansion at question, and probably a good portion of those, because several big states like Texas have already said no. So those are the core questions there. The rest of the ACA stays the way it goes. Frankly, from a cancer care perspective, it's not that big of a deal. Most people would be better off not having Medicaid coverage anyway, honestly. and I think there's some studies out there that's saying that you have essentially the same outcomes if you're uninsured as if you're a Medicaid beneficiary. It should be better than that, but that's not how it is today. And so if it's possible for those folks that would have been covered under Medicaid through the expansion to instead get private health insurance through the exchanges, that actually would be a better result for those individuals.
My final question involves the biggest obstacles to implementing the Affordable Care Act.
My opinion, the biggest obstacle is that the federal government's not really set up or ideally designed to take on a task like this. And so, or at least the parts of the federal government that are tasked with it are not really well suited to the job. You know, I think if I were there, I would have asked the people that run the federal health and the Federal Employment Health Benefits Plan, the FEHBP, to actually run this program instead of asking CMS to do it. I mean, CMS is really set up as a claims payer. It's a place where paper and electronic requests for money come in and checks go out, or electronic transfers of money go out. It's not really an administrator of a health insurance program. And maybe it should be, or maybe it shouldn't be, but the fact is that it's not. So that's going to be the most interesting thing to me, I think, over the next couple of years, is seeing how they staff up appropriately and get the right talent in the door to actually make this a success. And I think it will be very difficult for them.
I appreciate, Matt, that you took a rather complex area of discussion and simplified it for us.
Sure. No, I'm glad to do it.
Matt Brow, Vice President of Public Policy and Reimbursement Strategy for McKesson Specialty Health and for the U.S. Oncology Network.
Thank you, Selma.
Thank you.